Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, welcome to this week's episode of the Healing Pain Podcast, where we're discussing the evaluation and treatment of neck pain and chronic headaches. Our expert guest this week is Professor Matteo Castaldo. Matteo graduated as a physiotherapist in 2007. After a few years of practice and many courses in manual therapy, he decided to pursue a research PhD with a focus on chronic neck pain, chronic headache, its mechanisms, and central sensitization. Today, he's working as a postdoctoral researcher exploring headache and other chronic pain syndromes. He works part-time as a treating clinician specializing in headache and neck pain, as well as teaches postgraduate courses to physical therapists and medical doctors. On today's episode, you'll learn all about the role of biomechanics and neck-related structures in headache-type pain, how to properly assess headache and neck pain, why physical therapy is helpful for treating these conditions, and the shared mechanisms between neck pain, headache, and central sensitization. And before we begin, don't forget there's still time to take advantage of our Summer 2020 free book giveaway. All you have to do is visit our show on Apple Podcasts and leave us a review, and then fill out the form by going to the URL www.integrativepainscienceinstitute.com/giveaway, and I'll send you a free copy of my book, Heal Your Pain Now. Remember, there's only 50 copies available, so take advantage of this limited offer while it lasts. Okay, let's begin, and let's meet Professor Matteo Castaldo and learn about neck pain and chronic headaches. Hey, Matteo, welcome to the Healing Pain Podcast this week. It's great to have you here.
Oh, thank you, Joe. It's a big pleasure to be here with you. I was really looking forward for this interview.
Yes, I know you reached out to me probably a couple months ago now, and you said I completed my PhD work, and I have some really interesting things to discuss with regard to headache pain and neck pain and central sensitization. And those are all topics that we've covered on the podcast, but we haven't really gone deep into neck pain and headache, some of the things you're going to talk about today. But tell us how you got started looking into some of these topics.
Yeah, because I graduated as a physical therapist in 2007 in my hometown university in Parma, in Italy. And then I took, like many of us, many different manual therapy courses, different coach. And I needed to move part-time, as I'm still a clinician, to the research world. In 2012, 2013, I started and I developed my project, my PhD project at the Aalborg University in Denmark. So I have to say that in the last few years, I've been part-time a clinician, treating mainly musculoskeletal dysfunction, particularly headache in the last few years, and still a researcher. When I completed my PhD, and it was 2017, in that period I was moving from neck pain to headache world, so always studying tension-type headache and in particular migraine and the central sensitization mechanism going on in the brain of those kind of patients.
Mm. So you've mentioned neck pain, central sensitization, headache pain, migraines, tension-type headaches. What did you study first? Because they're all related, but what did you really start with first?
I started from neck pain. My PhD was mainly a comparison between central sensitization, that if it was more prevalent and more predominant in whiplash patients as compared to mechanical neck pain patients. Mm-hmm. As we knew previously from the literature, that if in whiplash patients we had clearly signs of central sensitization, even in the first stages after the car accident, in mechanical neck pain, literature was a bit unclear about that. So we wanted to assess for musculoskeletal dysfunction, for the health situation of those kind of two different neck pain population, and for some kind of sensitization mechanism, just to assess them, compare them, and to see if there was really two different population, or if the same mechanism was the same prevalent between them.
Mm. So from your research, do we know why, or do we have any idea why central sensitization tends to happen more in whiplash patients than those with mechanical neck pain?
Yeah, it seems to be much more prevalent, as you correctly said, in whiplash patient. And something that is really strange is that in whiplash patients, when it develops quite soon. We have some studies showing that after people who still have neck pain or neck complaints or disability after 1 year, they already had some clearly sign of sensitization after the first month from the accident, which is kind of strange because for many other chronic pain, musculoskeletal, and not just only musculoskeletal conditions, we know that central sensitization is linked to the duration of the pain. So as much as you suffer from a specific condition, and the more you become likely to develop sensitization. But in whiplash, it seems that it's something that is really linked to something also genetic. Now, there are a lot of studies about the genetic work, as there are some patients that are really so predisposed to that can develop central sensitization even with a small trauma and really, really fast. We know from some Australian research group that also the stress mechanisms are involved. So there are some people that probably are just more vulnerable to this kind of mechanism. So their stress reaction is in some kind of way, we can say, bad and not as good as other people. And probably those patients can start developing psychological complaint, catastrophizing, more pain, some hyperalgesia, and all this stuff that are linked to central sensitization development.
Interesting. So how does that, so for clinicians listening and they're seeing people with whiplash type diagnoses and injuries, how would that change their treatment approach when working with someone who has chronic pain?
Yeah, it's really different because if you're just managing some kind of patient with musculoskeletal dysfunction, and if they don't have signs of central sensitization, you can use your biopsychosocial approach, but you can mainly focusing on the dysfunction, on exercise, education, manual therapy, manipulation, or whatever. But if you have a patient that you can clearly recognize from your assessment, from your baseline assessment, that has strong signs of central sensitization, we have to change the way we approach the patient, as we know that manual therapy enough will not be probably sufficient, as we have some literature showing that when the patient is really high sensitized, they have a lower response to manual therapy approach, and they have a lower response to medication as well. And that's something that is really linked to headache patient. As we know, for example, about the symptomatic medication like triptans that the patient can take to try to interrupt the headache when it's starting, that if the patient is really sensitized, the triptans are less effective. This is something that has come up from 2 different studies, and it's really interesting that when probably your brain is already too much sensitized, even the efficacy and the effect of the drug, symptomatic drugs, is not the same as it was before. And the same is happening with manual therapy and our approach.
Interesting. So clinicians can start to kind of piece these out into 2 different boxes almost and say, well, if someone seems like they're sensitized, and I want to talk about signs of central sensitization in a moment, but if someone seems like they're sensitized and they have a whiplash type injury, then less manual therapy and more toward the psychosocial aspects of pain coping for that patient.
Yeah, definitely. I think that it's really something that you can decide in the first assessment. As you can say, like you were saying, you can put the patient in 2 different kind of boxes. In the one in which you decide that the patient has not really clear signs of sensitization, you can probably more work on the manual therapy, some exercise, and then some kind of education. But when you have a patient that really has strong signs of sensitization, probably also the management needs to be more multidisciplinary, as you need more often a psychologist. But as when they are sensitized, they have some catastrophizing, bad coping strategies. They are depressed. They show signs of anxiety. They are not as motivated as the other one in trying to improve their condition. So they are not motivated at all. And so sometimes it's really also a thing about motivation and finding the right people following the patient 360 degree. Otherwise, you will just be one in the list probably of those chronic pain patients. We had a lot of failure with different osteopaths, chiropractors, physical therapists, drugs, and whatever.
And then when we look at central sensitization in that population of those with whiplash, are the signs and symptoms of central sensitization the same as, let's say, chronic low back pain, or do they present differently?
Yeah, you mean when the patient shows signs of central sensitization, if they got the same features?
Yeah.
Yeah, they're mainly the same. As you can mainly, in your assessment, you can recognize if your chronic musculoskeletal pain is sensitized or not from the interview. So from the anamnesis and the question that you are, when you're just interviewing and talking with the patient, we've got some questionnaires The most important is the CSI, the Central Sensitization Inventory, which is a good instrument as it usually has a cutoff of 40 points. And if your patient is fulfilling more than 40 points, mainly it's considered highly sensitized. And is a very useful item also to show the patient that there is a test saying that probably they need something more complex, and their problem is not a localized problem anymore, but it's something that has spread more and so needs to be treated in a different way. And we use, but that's more for the research setting, the QST, the quantitative sensory testing. We have many of them to assess allodynia, hyperalgesia, as one of the main clinical features, as we were saying, in both whiplash and chronic low back pain, if they are sensitized, is that they got a widespread pain even in healthy body part. So maybe the patient is coming to the clinic complaining some neck pain or low back pain, but if you test and assess other body part, they should be healthy. So they should not have a kind of hyperalgesia or allodynia. You will find some of that also in the healthy body part.
So how did you move on from whiplash into different types of headaches and the assessment and treatment of headache?
Yeah, it happened when I was almost in my last year of the PhD. I was a bit confused. I was saying, okay, now I'm almost getting my PhD, but what I want to do later, I want to be a researcher, a clinician, a teacher. I want to do all of them, making my life crazy or whatever. And the idea was to keep on going with the research. So still going part-time research and part-time as a clinician. I didn't want to stop with my patient. And I think that the most interesting question comes from patients. I mean, everything that I studied in my research activity in the last few years has come from some specific questions that I had when I was treating my patient, assessing my patients. And as I started to work with headache patients, and I was mainly treating neck pain patients, whiplash or mechanical neck pain, and many of those complained also of headache, I started to get interested into headache, and I started to, study literature and looking at what was still lacking into literature. And I was involved into a big international project in which I was the leader, the responsible for the Italian part, and we had also Denmark and Spain involved. And it was a very long longitudinal project that has lasted for 2 years. And it was mainly on tension type headache patient. And after that, I moved into migraine, as I think is much more interesting, even if at that time I thought that probably as physical therapists, we will not be so much successful with migraine patients. And after a few years, I have to say that I was completely wrong, because if you study the literature and in the clinic, if you treat a migraine patient, you will have some huge, impressive results as well.
I'm glad you brought that up, because I have read that myself, that physical therapy is not indicated works poorly for migraine type headache. I think a good place to start is, can you explain to us and articulate the difference between a tension type headache and a migraine type headache as far as a clinical presentation?
Yeah, the clinical presentation is very different. So usually, even if the patient hasn't got a medical diagnosis, you can strongly divide in two big categories your headache patients. As mainly the two most important characteristics as migraine patient is that the pain is located unilaterally, just on one side of the face. Sometimes it could shift, but not together at the same time. And the pain is usually in that area around the eye, and is a kind of pulsating pain. When we move to tension type headache, usually the pain is bilateral, and the pain is something that is very dull, is a kind of itch that the patient feels like pressure around their head. And some other characteristics are, for example, that usually migraine leads to much more disability. And that's something that makes a bit of unclear in the classification. As if you see the epidemiology, we know from the literature that there are much more patients suffering from tension type headache, but those suffering from migraine, they have a stronger disability. As right now, migraine for the global burden of disease studies is classified as the third most disabling medical condition worldwide. So it's ranked number 3, so quite high. And that's not really happening the same for tension type headache. So what's really happening? That the patient with a kind of diagnosis of tension type headache, mostly they are not searching for medical diagnosis, but they just will try to manage themselves with some, basic medication or lifestyle, or sometimes some exercise or whatever. and the migraine patient, they really have a strong and disabling pain, which could last also for 3 consecutive days, as the international criteria says that a migraine attack will be up to 72 hours without resting, without any second without pain. And another, just to complete, another big difference is that usually during the migraine attack, the patient has some kind of nausea, sometimes has got phonophobia, has a kind of generalized hypersensitivity that makes you understand, and that's for when we move about the pathogenesis, that there is something in the brain that is hyperactive, hypersensitive, and so makes these patients too sensitive to every kind of different stimulation from outside and even from inside. So we can say that migraine is much more complex than tension type headache, even if tension type headache is much more diffused around the world. So the prevalence is for sure much higher in tension type headache, but the disability is much higher in migraine.
So I want to talk about the causes of each of those, but just kind of weaving this into what you mentioned earlier with regard to central sensitization. Does central sensitization occur both in migraine as well as tension type, or is it more primarily in the migraine type headache?
Yeah, it could be present in both, as there are many studies showing that central sensitization is a main feature of primary headache, and both the headache form that we are talking about, they are kind of primary headache. So we have good studies since the early 2000 years, so probably since in the last 20, 25 years, we got good scientific evidence explaining and reporting that in both tension type headache and in migraine, central sensitization could be present and sometimes could be the predominant part of the problem, even if we know that the migraine brain has much more studies on that, has been studied much more in the last few years, as it's more interesting, because usually who pays for scientific research are, companies and whatever, and they are much more interested in finding a specific drugs which is going to target the migraine brain as compared to tension type headache, which they take a painkiller or whatever just to manage from themselves. But if we talk from the literature, we got good evidence that central sensitization could be present in both forms of both migraine and tension type headache as well.
Yeah, I mean, I've seen some of the MRI studies and the functional MRI studies on migraine. They're interesting from a clinical perspective. That kind of wave of depolarization that happens over the entire cortex is interesting to clinicians, but both of them can be disabling conditions for patients. Can you talk about the causes of each, if they're distinct with regard to tension type and migraine type headache, with regard to, I guess, biomechanical, psychosocial, and then some of the lifestyle factors?
Yeah. As we were just saying, there are much studies on migraine, but we have some good evidence also for tension type headache. As something that is really missing often and we are forgetting is that there are good evidence studies since the 80s trying to link them together and saying that probably they are just two parts of the same trouble. Mm-hmm. So it's a model that is called a continuum model, in which their idea of these different authors, but many different authors had the same idea and believe in that they are just a continuum in which the tension type headache is the one with less disability, and in some kind of specific population, probably with a genetic predisposition or whatever, they can evolve towards the most disabling forms of migraine. But from our viewpoint, and that's the basic as physical therapists, that's really important to know. When we have a patient and we don't know which kind of headache they have, we could even say that we are not really interested in the fact that it's a migraine or tension type. For sure, in the interview, we will have some information that we will have our idea of what's the type of headache that the patient is presenting with. But the most important for us is finding some kind of musculoskeletal dysfunction which are related and linked to the headache of the patients. And this is regardless the kind of the medical diagnosis. The medical diagnosis for sure is much important about the medication, about some exclusion criteria, about some red flags which needs to be investigated when we deal with headache pain, especially if you got a headache that is changing in characteristic in a person which is not that young as when the headache started, as usually headache starts in young age. But otherwise, when we have our patient, we just have to assess the musculoskeletal dysfunction which are relevant for those kind of patients. And we have good studies saying that those dysfunctions are prevalent in both tension type headache and migraine. So whatever is the diagnosis. When we have a patient, the most important thing to do as physical therapists in order to be able to say, okay, I can take you as my patient that I'm going to try to help you with your disability, with your frequency, with a headache intensity and whatever, with your symptoms. I need to find the link between your neck or temporomandibular joint and your headache. Otherwise, I will not be the professional who can help you.
So there's a connection, you're saying, between the structure and function of the cervical spine and someone's headache pain, whether it's tension type or migraine.
Yeah. And the idea is mainly it comes from neurophysiology, as we have in an area, a particular area, which is called the trigeminal cervical nucleus, which is receiving afferent information from both the trigeminal nerve, especially from the ophthalmic branch, and the first three division, the first three cervical spine nerves. And this creates an effect which is called a convergency effect, in which all the afferent information goes on the same station and then they are projected upwards towards the cortex, the thalamus, the hypothalamus, and so many different areas which are involved in pain modulation and pain processing. And because of that, it's really, really common that regardless the medical diagnosis, you can find a headache patient that when you go to stimulate some specific neck area, it could be joint, muscle, or whatever, or with some specific test and movement, you can reproduce the head pain that is usually felt in the patient during the attack. And that's very strong, I think, because if you think to how does it work usually a neurologist interview with an assessment with a patient, they're just asking stuff, they are having neurological assessment for sure, that is highly important, but they are not trying to reproduce the head pain that the patient is usually experiencing. And so we could be the only professional that can directly show to the patient that we can interact with their head pain, as we can move something in the neck that they don't know what's really going on, that can reproduce their headache. And it's very strong for the patient, as the patient say, okay, probably he understood something about my headache, as he is able just by pushing or moving something to reproduce my head pain. So this is very effective, especially when we have a patient that has a lot of failure in his history for his headache. So has tried many different medications, has tried many different healthcare professionals. And so maybe it's coming to us just because we were treating the sister or a colleague or whatever, a parent. And so it's not really motivated. But after that, if you can show that you can have a dialogue with their head pain, that's really strong for the patient. And it's really impressive for them.
Yeah, I think as professionals, sometimes we forget that a really thorough physical evaluation, just because we do it every day over and over and over again, but it can be really validating for a patient when you're doing something that reproduces their symptoms that no one's been able to see anything on an X-ray or an MRI. And as you mentioned before, a basic evaluation may have missed that, but they come to your office and you place your hands on them and boom, the pain is reproduced. And of course, later on, if you can obviously, alleviate the pain somewhat, then that's obviously the best case scenario. Yeah, that's the best case. So talking about manual therapy specifically, manual therapy is kind of a big term. There's lots of different techniques and approaches. What does the evidence say with regard to manual therapy for the treatment of headache?
Yeah, I think that regarding manual therapy, we have different very important information. First of all, we know that neck pain is highly prevalent in all headache pain. So it's ranging something between 75 and 90%, depending on the diagnosis, have a comorbidity of neck pain as well, not just headache. And most important is that quite often neck pain is considered as something that could start even earlier before the head pain attack and could last until the end and even for 1 or 2 days after the attack, but is not considered in the diagnostic criteria, even if the nausea, which is less predominant, is considered as part of the diagnostic criteria. So it sounds quite strange that the neck pain is not considered, even if it's so prevalent and so important in headache patients. Second, what is really important and allow us to treat with manual therapy those kind of patients is that there is a battery of tests that has been studied a lot in both migraine and tension type headache from a colleague, a German physical therapist, which is Kerstin Lutschke, which she studied all the different manual therapy tests that we can use to assess our patients from manual therapy approach. And she found that there are 6 different tests which you can assess the patient in like 25, 30 minutes, and finding positive test, you can say that you can treat the patient. And when you move to the literature, we have some systematic review and meta-analysis in the last 5-6 years saying that manual therapy could be effective as much as the drugs, especially in the short term, but even in the long term, after 6 months that you stop with manual therapy approach. So you don't have any negative effect with manual therapy as compared with drugs, for sure. But it's something that is not considered, as we have some guidelines, specific American guidelines, neurologist guidelines, saying that physical therapy and manual therapy should be used as treatment, especially for tension type headache. But how often does it really happen that a neurologist is sending to a specialized musculoskeletal physical therapist and headache patients? I don't know the situation in your country, but at least in Italy, it's not really happening so often, even if in the guidelines, even the European guidelines are saying the same, that we should treat muscle and joints of our patients, headache patients, as this could lead to an improvement of symptoms. But this is usually not considered.
Yeah, I agree. I don't think it's, considering how many people struggle with headache, it's almost like chronic low back pain. Almost everyone has a headache or migraine or a tension type headache when you start asking them at one point in their life. But I think the referrals to, practitioners like you and I, who are physical therapists, is probably quite low. But yeah, as you mentioned, people will go and pick up Tylenol and Advil and Aleve and potentially things that are even stronger. I've even had people on Neurontin for, migraine pain that really had little effect on, an outcome at all. So just getting back to that manual therapy. So if we look at, like, let's say massage therapy, if we look at joint mobilization, if we look at joint manipulation, like a high thrust grade 5 manipulation, are any of those more effective, or are they all just kind of treating a similar mechanism?
Yes, when we speak about manual therapy, there is always this debate going on between is it better to just mobilize the spine of the patient, or we need a specific spinal manipulation in order to achieve a better improvement? And there are good papers showing it's better manipulation, and other ones showing that it's better mobilization, and some others saying that the results are almost the same. So probably, as we don't, if you figure out how many different manual therapy approach do we have worldwide that has developed in the last 30, 40 years between the USA, Europe, Australia, or whatever. To me, that means that there is nothing that is better than the other one. Otherwise, we will all study the same manual therapy techniques. If there are so many teachers, so many courses, it just means that it doesn't really matter what you do. I mean, you need to find the specific and the right approach for that specific patient, which is not always the same. As we know that, for example, also what the patients want to have as a therapy. If they want to be manipulated, they will be better responder if you manipulate them. If they want to have a massage and you're going to say, no, you just have to do a specific therapeutic exercise, even if we know that probably the literature will say that for low back pain it's better to exercise instead of massage or manipulation, you will have a less improvement, as the patients were expecting something else. So the expectation also needs to be, matched. So we don't have any technique, any approach that is correct worldwide and is the one that is, the right one for every single headache patient. The most important is to rely on our musculoskeletal assessment. And if you find that there are some joints, there are some muscle, there are some movements that are painful or producing and alleviating the symptoms, you just need to work on that. And I think that is not really important which specific technique you use. But mainly, coming back to manipulation and mobilization, mainly are two different ways of reaching the same goal. Sometimes it's working better on one of the two, and sometimes probably is working better the other one, but it's something that you can decide prior to, assess your patient and to dialogue and to speak with him and assess what they want to have and what you think that is going to be better for them.
And along that same theme with regard to exercise, there are exercises that we can give people that are specific for their neck and head, or there's kind of more general exercise like aerobic conditioning or strengthening, let's say. Is there a certain approach with regard to therapeutic exercise that has proven to be more effective for these types of patients?
Yeah, again, also here we know that especially migraine patients can have some kind of a good improvement with aerobic exercise. It's still just a bit unclear how often, what is the dosage, the optimal dosage for those patients of aerobic exercise. But it's something that is really important, because something that we didn't say before, but is really prevalent in our migraine and tension type headache, is that they are quite lazy. They are not moving at all, as probably they experience some kind of, the pain was going worse with some kind of running or biking or whatever. So they stopped, and probably also the neurologists say that you don't have to train, otherwise you will, you will have some strong symptoms. But that's true during the attack. But if we think about a prophylaxis made by aerobic exercise, we have some papers showing that those patients can have a good improvement. As the same with therapeutic exercise. Also with therapeutic exercise targeting the deep neck flexor, for example, or some mobility exercise, everything could be useful for those patients. We don't, for manual therapy, even here, we don't have something that is definitely better than the other. But most often, this kind of patient needs to have some manual therapy approach, especially in the first stage of our treatment. Some therapeutic exercise, some change in the lifestyle, so to be more active, to eat well, and all the things that could help to improve their symptoms. So there are many studies going on right now, and nowadays we just know that it's important to take into account all these different aspects. So from the therapeutic exercise to aerobic exercise, but there is no just one approach that is better than the other.
And in your research, we talk about food and nutrition a lot in this podcast. In your research, I know there's some information with regard to certain foods being triggers for people with migraines and other types of headaches. Has that come up in the PT literature much, or is that still kind of tucked away a little bit more in the nutrition and dietetic world?
Yeah, it's something that has been studied with some kind of diet and eliminating some kind of aliments that we know that are can exacerbate the pain, the head pain of the patients. But it's not really linked to our world. I mean, as a physical therapist, what I do with my patient when I am assessing them, I just investigate with some question if they have identified some kind of food, some aliments that when they eat them, they get worse with their headache the day after probably. And I just have some suggestion for them, trying to make some small changes in their diary, just to see if something changes. And to assess if there is a change, you need to assess the patient for at least 1 month. Mm-hmm. Something that is really important is the diary, in which you can see, and the patient can write every single triggering factor, like could be, yesterday I ate some chocolate or white wine or whatever. But then if I understood that probably it needs to be approached in a different way, in a more complex way, I send them to a professional which is specialized into nutrition.
So as you and I are talking here, you're a wealth of information on headache, which is great. But as I think back to when I used to train more entry-level physical therapists, a lot of new physical therapists are actually a little fearful to treat headache patients. They're scared to put their hands on them. Those types of patients can be very sensitized, which means they can be very reactive to any type of treatment. Are we going kind of deep enough, I guess, in entry-level training with regard to migraine and tension type headache for the newer practitioners?
Yeah, I think that mostly they are afraid, as we are not used to treat headache patients. If you think, what I usually say in my courses is, if you are here, probably is because you never had some kind of specific training into headache. When you go, for example, and you want to update yourself with the 2-day courses on low back pain or neck pain, probably you are used to treat this kind of patients, and you had already many courses on the management of neck pain, low back pain, or rehabilitation of hip, knee, or whatever. But when you approach, as a clinician, the headache field, probably something completely new. So you're scared, you're afraid, because you're touching something that is very sensitive, because you're not used to treat the head pain as compared to low back pain, in which you trust yourself, you trust all the patients that you treated with success. So mainly, I have to say that also in my courses, I see that even very experienced manual therapists are kind of afraid when they have to explore the upper cervical spine or some tissues in the frontal part here of their neck, in which it's important to find some specific areas in which can reproduce head pain. And that's basically, I think, as we are not trained in our basic background to manage headache patients. So it's something that when you decide that you want to approach this kind of patient is something that is mainly new for our colleagues.
So if there's a newer practitioner, a newer physical therapist listening to this, what would be a good first step for them? So maybe they didn't learn a whole bunch about neck pain or about migraine pain in school, and they're looking either for, other than this podcast, listening to you, a resource. What's a good place for them to start?
Yeah, I suggest to, for example, sometimes I have some email in which there are students at the last year of university writing me and asking information about courses on migraine and the management of headache. And they say, will I be able to follow the course immediately after that I graduate from university? And for sure they can, but I always suggest them to take some other, I would say easier, but it's not the right word, some other courses of something that they will treat more often in the clinic as they are not experienced. So my suggestion is always start working in a clinic, see the patient that you are more interested in, pathology that you see more often in the clinic, and then take some specific courses about that. Then after a while, like you said, if you have some manual therapy background or some specific neck background, it's going to be easier to approach the headache world. Otherwise, you can do that, but it's going to be something that probably you lose at the cost like 20-30% of something that is going to be explained, as you need to go back at home and search for a lot of stuff because maybe you never heard that the technique, you never heard this kind of theory about the pathology and whatever. So I think that a general courses of manual therapy and something specific about management of neck pain or neck dysfunction is something that is going to be really helpful before approaching the headache world.
Yeah, great suggestions. What's missing from our research, or what new direction would you like to see the research go with regard to headache in the physical therapy field?
Yeah, there is something huge is really missing. That is I think is for that reason that medical doctors and neurologists are not really, we are not dialoguing with them a lot in having patients, receiving patients from them. That is, they say, okay, you have some good evidence, scientific evidence, and clinical improvement as well, showing that you can be helpful for those kind of patients, but you need to be able to prove why. So what's really happening when you treat your patients? So why are they improving? As if you think, when you target with a drug, you are targeting a receptor, and it's just a molecular binding, and so you know exactly what's going on when you give one drug to the patient. But we are not really aware of what's going on in the brain of our patient when you're applying a manual therapy technique, if it's painful, not painful, or an exercise, which kind of mechanism we are modulating and activating. And for that, the next big project that we are writing right now, I have to say that in the period of the quarantine in which I had to stop with the clinic and with patients, I had time to write two, and now I'm completing the third one, big research project. And one of that is exactly about that. We want to show with a functional MRI study what's going on in the migraine brain before and after our manual therapy techniques. So if we are really able to modulate, especially like the periaqueductal gray and nucleus cuneiformis and other brain area that we know are involved into pain modulation, just to be able to show to the scientific world what's really going on with our techniques. So why we should be healthcare professional that should assess and address those kind of patients. We need to be able to show what's really going on and why it can be helpful. And I think that this is the big missing link. Otherwise, yeah, you can have your clinical improvement, and if you are good, you will always have a lot of patients. But if you want to have something that is good in general for physical therapy world, I think that we must be able to prove what's really going on. And we are designing this study, which should start in 2021, which I think is going to be very interesting, as it has never been done before. And so we just have ideas of what's going on. As we know from other studies, what's going on with manual therapy techniques, that we have a kind of inhibitory effect and modulating of the pain system and whatever, but nothing specific about the migraine, which we know that is a more complex brain.
I like that. I mean, I think that's really useful for the profession because it takes it beyond this person lacks some range of motion or flexibility or strength from the biomechanical, and really places it more on the neurophysiological level. And so, yeah, we may be helping someone with strength and range of motion, but there's also more happening with regard to neurobiology.
Yeah, and most important, we need to be able to speak the same language as medical doctor and neurologist. So we can't speak from the biomechanical model, as they are not aware of that mainly. A neurologist doesn't know anything about the rotation of C1 or C2, of the axis of C1, or whatever a trigger point it is or not. So we need, as headache usually is their word, we need to be able to communicate with them, to speak the same language at a good scientific level, and to explain what are we doing, but not from a biomechanical viewpoint, as they are not interested. I tried to have so many conversations with good neurologists that were open to physical therapy, but all the time there was the same question. They were interested, that we were having interesting conversation, but there was a point in which they said, okay, but can you prove what you're saying? I know that if I send the patient to you, probably the patient will improve, but I need to know what's really going on before it becomes something that is the routine, because before it's normal that every single headache patient is screened by a specialized physical therapy.
Yeah, great. Well, definitely keep us up to date on that study. We'd love to hear about it when it comes out. And you're, of course, welcome to come back. In the meantime, how can people follow you and continue to follow your work?
Yeah, as a researcher, they can find information on a big network that probably they know that is ResearchGate, in which you can find all the information about the researcher and also all the published paper. And if they're interested into having some courses into headache field, I'm teaching to medical doctor and physical therapist since 6 years, many different courses. So as I said before, the idea is that if there are already experienced physical therapists that had some manual therapy background, probably is something that could be interesting, and it's something that could give a lot of new possibilities. As we said before, headache is very predominant worldwide. So they are really, I would say, waiting for us. As something that we didn't mention before that is highly important is that even if in the last 20 years there has been a lot of studies on drugs and medication specific for migraine, we are a bit far away from getting 100% of patients responding to medication. So they are still searching for something else, those patients, and probably they just need to meet us. I'm not saying that we will resolve 100% of the problem. As to be honest, we have to explain to our patient that probably we can help them, we can improve some of the symptoms, we can decrease the use of medication, probably decrease the disability which is associated with headache. But to be honest, we have to say that they will still be headache patient. But this is the same that also an honest neurologist will explain the patient, as we can just try to manage those symptoms, but they will never fix at all a headache patient. And so I think that is something that we can be really helpful for those patients. So I think that if they are interested, they can write also me and via email, and I can give some good suggestion about what to read, where to start from, or good colleagues that also work on that field. So definitely they can contact me and I can give all the useful information that I have.
And you also have a website too they can find you on, is that right?
I have a website that is the one of my clinic. I'm the owner of that clinic, that they can take a look at it. But I'm sorry that it's just in Italian, unfortunately. So about information is better on ResearchGate, as ResearchGate is in English, and they will find everything about me and also the email for contacting me. Otherwise, they could look at polyambulatoriophysiocenter.com, which I can send you later, which is the website of the clinic, and they can find also there some useful information.
Okay, great. We'll make sure to include the URL to your ResearchGate so everyone can check out your research. And of course, they'll be able to find your email there as well. I want to thank Matteo for joining us on the Healing Pain podcast this week. Make sure to share this episode out with your friends and colleagues on Facebook, Twitter, LinkedIn, wherever people are hanging out talking about headache pain and, of course, persistent or chronic pain. I'm Dr. Joe Tatta, and we'll see you next week. Be well.
Hey, Joe. Thank you very much. Bye-bye.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.